Good morning, everyone. I'd just like to start by thanking the organisers for inviting me to speak, but a big thank you actually for inviting me to listen, because so far the listening I've done has been really interesting, and I feel privileged to be here. Also a big thank you to Marianne for a very generous introduction. Thank you. I must say I was a bit curious why I as an obstetrician was being asked to come and speak about what is a midwife. And I thought about it a bit, and the more I thought about it, the more in fact I realized that it was a bit more complex, and actually a doctor can be a midwife. And that I'm going to elaborate on a little bit more later, as I've been talking about being a midwife. Now, when I was a young 21-year-old medical student, and this was in London, doing maternity, I very quickly became aware of the power of the midwives. Midwives are powerful people, and when you're a student, you know it. And that was my first kind of assessment. Good role models, not so good role models, but powerful people, midwives. Since then, I'm now looking 40 years on, looking back, I think I've learnt a lot about the different dimensions of the midwife, and in a way I've come to a certain understanding which I'm now going to sort of elaborate further. I'm really completely convinced that the midwife is the primary caregiver for normal birth. It shouldn't be the obstetrician or the doctor, it should be the midwife. And that's for all aspects of birth, from antenatal care through to care in labour, care afterwards, care of the family, education, etc. I think and in some ways one is talking about the ideal, but I think a midwife or midwifery embodies what I always try and teach students as medicine or healthcare is about the 3 H's. It's about what we do with our head. We've got to know things, we've got to query. It's what we do with our hands. We've got to be practical, competent, skilled. But we often forget it's also about our heart. And it's that aspect of being a healthcare worker which often goes. It's the emotional aspect. And I think Candice talked about that as well when you talked about being a midwife. I think also I'm well aware that it's a job which requires a lot of wisdom. And wisdom because it's doing contradictory things. There are times where it's all about waiting, watching, quietly, allowing the natural process to happen, which mostly it does. But it's also about watching and waiting and sometimes picking up that very subtle sign that something's perhaps not going right, and acting on that subtle sign in a responsible sort of way by maybe referring or taking a different course of action. And then there are other times where, while waiting and watching, something happens very suddenly, and the midwife has to spring into action, doing things, emergency treatment, calling for help, and it's this kind of contradiction and wisdom, I think, of knowing when to do what, which is important. I think, and I've observed that I think that midwives require an awful lot of emotional resilience to cope with the extremes of emotions in their clients, sort of pain, and it is always painful, labour, and you are watching women in pain. Sometimes there's anger, sometimes joy, sorrow, as we heard this morning from Malika, guilt, and of course a privilege to share the joy and the happiness, but it's a lot of conflicting things being a witness to all the time. Now, the one aspect of the midwife I wanted to talk about quite a lot, because it's in a way where I come from, is midwives save lives, and I think everybody knows that globally and in South Africa, a midwife is absolutely crucial for saving the lives of mothers and babies. And I know we're more talking here about the experience of birth, but it is a fact, and a very sad fact, that in South Africa, 1,500 women die every year in pregnancy. and there are 20,000 stillborn babies. And it's also higher rates than should happen in South Africa, because we're quite a high-income country. It shouldn't be like this. And it's mostly poor women and women in rural areas, disadvantaged women, who have higher rates of mortality, actually, for the mother and for the baby. And for me, that's always been such a sort of challenge to try and sort of reverse the inequities and give everyone the chance to survive childbirth and have a baby that survives. A lot of the problems can be prevented, and I think the midwife is absolutely key. Sometimes when I talk to midwives in my hospital, Mowbray, they say, oh, well, talking about maternal mortality, it's all for the doctors. And I say, no, it isn't. It's every time a midwife prevents a problem, gives nutritional advice, prevents anemia, she could be preventing a maternal death. Every time she picks up a very subtle change in the blood pressure and decides to maybe refer, or then she's preventing a maternal death. And obviously the emergency management, being able to very, very quickly recognize when something's going wrong and doing the immediate sort of first aid can make all the difference. So I see midwives as being absolutely crucial at the coalface for saving lives in South Africa. The other aspect, I think, which for me is important about a midwife, and this is really particularly in facilities, is a kind of midwife as a team member. And here I think there are sometimes some sort of perceptions of conflicts which we should strive to avoid. Firstly, thinking about a midwife as a team member, they're often the person who links with all the different staff members. It's in our hospital with the cleaners, the porters, the procurement of supplies. They enable the environment. I worked in Zimbabwe as a junior doctor when the doctors went on strike, and there were a few people in the hospital. We managed to keep it going, but when the midwives went on strike, no, we didn't know where anything was kept. Just as sort of simple as that. So, we're not always so knowledgeable about the environment of what is needed. I think the midwife is often the linkage with the family, because she is the continuity, and that's an important role. The linkage of the midwife with the doctor, and I think there is potential cause for problem which we should strive to overcome. I think it's the idea of whether you're a team or working together, seeing yourself with different strengths, or whether you see yourself as just a collection of individuals with completely different approaches, and then the team won't work. And people talk about the midwifery model of care and the medical model of care. And there shouldn't be such a dichotomy. We're actually dealing with one patient, one woman, and she may need either. And they're both complementary and overlapping. And the most important thing is to be sort of woman-centred, with her at the centre of it. And occasionally the whole midwifery model is the appropriate one. But there are occasions where medical intervention is absolutely vital. And we mustn't make the two things seem conflicting. I think doctors need to respect that the midwife is the expert in normal birth, and not encroach on that area. And midwives also need doctors for support and medical intervention when there are problems beyond their competence. Both need to respect women's choices. I think it is quite clear that every pregnancy carries some kind of risk. It would be a misguided midwife to have absolute belief that every birth will be normal, and it would be a very misguided doctor to treat every woman as though it's high risk and over-intervene. And certainly when I trained as a medical student in London, it was at the stage where people were over-intervening. They were doing too much. They were kind of medicalising the whole thing until consumers and women objected. It was so, and I think the doctors and nurses can actually learn a lot from each other, and particularly from their clients. And it's in this context of seeing that that there's a midwifery model, there's a need for medical intervention, where I say a doctor can also be a midwife. It's about a model of care. It's not necessarily tied to being a nurse. And a midwife can also do many of the things that doctors often do. I do think there's an awful lot of challenges facing midwives, and I think they are quite difficult to address. I think, as we've heard from Candice's work in an overburdened public sector, it is very difficult in that context to maintain compassion. It is really difficult to kind of every day see a woman coming in labour as though it's the first woman you've seen coming in labour, when actually maybe it's the 1000th woman you've seen coming in labour. And to keep that kind of heart and that compassion, I think, is a real challenge. And I think midwives working in the public sector need much more support, debriefing, encouragement to be able to maintain compassion. I think there's an awful lot of stress, and this is a stress I feel myself, of underservicing, because we're not actually giving everyone the care that they need. For someone like me is in charge of a service in a way which I know has imperfections, and you would like your service to be perfect, but you know it's not. But you're trying, and you are aware that many people actually, because they're poor and disadvantaged, don't have access to what's needed. You know, in many parts of Africa, women don't have access to caesarean section when they need them. In some countries, the caesarean section rate is 0.5%. You know, whereas then we have other sectors in the private sector where it's almost 60%. So there's a kind of mismatch. Some people are getting over-servicing and other people are getting under-servicing. And it's stressful working in an environment where you know you're under-servicing people on occasions. There's a burden of HIV, emerging medical problems, and that again is an additional thing for doctors and midwives. There's the problem of over-servicing, I think, has been talked about quite a lot. I think it's very difficult for a midwife to be working in an environment where the caesarean section rates are going up for no medical indication, where there's a tendency within birth to try and control it. You know, it'll be this day and this will happen. And actually quite a lot of women quite like that. They want to be completely in control. And I always feel that the one thing about midwifery is and about birth, it's giving people the confidence to deal with uncertainty. And we're very bad these days at dealing with uncertainty. We want to plan everything, and birth isn't about that. It's about dealing with uncertainty. I think some of the fears of midwives have been discussed, the challenge of maintaining and extending skills, this problem of litigation. I think there's a huge challenge to midwives and those working in the field of childbirth to see ourselves as advocates, and in a way I think this is what this conference is about. You know, we have to be advocates for women and for our different health workers within the childbirth care service. I'm just going to end with one thing, because I've talked very much about the service that we provide, but I just thought I should finish by saying what midwives have meant to me personally, and this is not as a doctor, but actually as a woman who's had 3 children. And each of my children actually were born in a different continent. One in Africa, one in UK, and one in Australia. It just so happened to be they came in different places. But each time by a midwife. And because I didn't have any obstetric problems, I hardly could get to the hospital on time. But the midwives each cared for me, and I can only express gratitude that each of them did not treat me as a doctor. One of them didn't even know, actually, but they treated me as a young person about to give birth, and for that I'll be eternally grateful. And just one story about my first child, which was in Harare Hospital, was he was a bit premature, 4 weeks, and the obstetrician, who was actually my sort of benefactor, superior, etc., felt in those days when the baby was premature, some people liked to put on a forceps. And he was saying, I think I must do this. And I think I'd just done my exams, and I knew this wasn't necessary. So I sort of started to say, well, I don't think it's necessary. I mean, I've read this. And then I suddenly thought, am I really meant to be having this kind of intellectual argument as the contractions are coming, and I might offend him, and anyway, this. And then the nurse, Sister Potsikaya, I remember, sort of whispered in my ear as he was fiddling around, "Push, Doc, push!" And the baby came out very quickly before there was any chance of forceps. Thank you very much.